Hello, my name is Lauren Schuler. I am an executive board member for Miles for Hips, and in this Team Week highlight of hip dysplasia around the world, I'm joined by Dr. Pablo Castañeda, who is a pediatric orthopedic surgeon and chief of international and destination surgery at Texas Children's Hospital. Dr. Castaneda is originally from Mexico City, established a successful practice there, then spent 7 years practicing in New York City before moving to Texas Children's. He has demonstrated unwavering dedication to pediatric musculoskeletal health with a primary focus on problems of the hip, including hip dysplasia, and emphasizing early diagnosis and intervention for optimized patient outcomes. Dr. Castaneda, thank you for taking the time to share your perspectives on hip dysplasia care around the world.
Absolutely. Thank you, Lauren. It's a pleasure to be here with you.
To start, can you tell us about yourself and how you came to be interested in hip dysplasia?
Sure. It can be a short story or a long story, but I guess I'll go for somewhere in between. As you mentioned, I am originally from Mexico City. That is my home. And during residency, which I was doing in Mexico City, I thought I would become a total joint surgeon and was interested in doing hip replacements, which I thought was a great procedure when I was a junior resident. And I still think it's a great procedure, but then I realized that the cause of a lot of these joint replacements we were doing was undiagnosed hip dysplasia. And I was like, well, this has to be a better way to be doing than placing these big metal chunks in there. And that's where my initial interest in then going into pediatric orthopedics began. So from that time on, I was convinced that pediatric orthopedics was my true calling. And because I had already focused on hip and hip dysplasia, I was sort of naturally drawn to it and have found it to be a fascinating topic ever since. So that's kind of the in-between story of why I like it. And as you mentioned, I've now had the opportunity and the privilege to see care provided in multiple different settings. So it's just enhanced my interest in understanding this condition.
That's wonderful. And something that I'm especially interested in hearing is how patients are screened for or come to be diagnosed with hip dysplasia and kind of your dual perspective on what that looks like in Mexico versus in the United States in both those practices.
Absolutely. And we could talk about screening practices all day. As you know, this is a relatively controversial topic. I've also been very fortunate to have been involved for years now with the International Hip Dysplasia Institute, which you know of. And that has given me an international perspective to see other countries. But you're right, my firsthand experience is in Mexico and in the US. So they're completely different systems. And even within those, I would say there are differences. In Mexico, I was very privileged to work at the Shriners Hospital for Children for many years, which was an incredible opportunity to learn and an incredible place to provide care for children. It is a true philanthropy, and the mission of the Shrine is to provide the highest level of medical care for children, regardless of their ability to pay. And naturally, that led to a huge number of very needy patients coming to us. And as a tertiary referral center, that was a slightly different approach to my other practice in Mexico, which was a private practice where patients had access to good health care. In the general term in the country, screening takes place in primary care. And for the vast majority of the country, that means pediatricians. Mexico differs from the US in that they did mandate nationwide screening by imaging, which is actually now in the Constitution, and children have just the way they have their health records, which have the immunization records on there. It actually states on there that they have to have some form of imaging taken before the age of 6 months. It doesn't specify whether it is ultrasound or x-ray, but in theory, every child has to have either an ultrasound or an x-ray taken of the hip. It's a little bit questionable because it doesn't state who provides the x-ray or what is done if dysplasia is identified, but I think it's a step in the right direction in at least bringing awareness to this fact. So the reality is that although all children should be screened, in Mexico, many children don't see their pediatrician on a very regular basis, and they might see a family doctor or might see a general practitioner, but they might not see an actual pediatrician for months. So at least having this sort of mandated does bring some awareness. Now, this is a relatively recent development. When I first joined the Shrine, the mean age at diagnosis of the patients who were presenting was 2.5 years. Not 2.5 months, 2.5 years was the mean age. So these were children who presented when they began walking, they were limping, and they get referred around. And by the time they came to us, they were 2.5 years old. That changed because we implemented ultrasound screening, and we actually documented that. And over the time that I was there, by working with an incredible team and working with the National Society and the National Pediatric Society, we actually raised some awareness, and that age is trending down significantly at the Shriners. And across the country, it is improving. But the sad reality is that many children still go undiagnosed in early infancy and get there too late. One of the things that happens with this imaging is if they get an x-ray at say 6 months and it's read as equivocal and they bounce around a couple of places to get somewhere, by the time they present to a specialist, they're coming up on a year. So you really missed the opportunity to treat this in an ideal way. In my private practice in Mexico, which was a completely different environment, that was in a relatively wealthy population, and all of those patients had access to excellent care. So in that population, the pediatricians were much more aware of this. And similar to the US, they were doing screening by physical exam for all babies and selective ultrasound screening for high-risk babies. And I would say that they were referring me a lot of the babies, even if they didn't really have a risk factor, because if there's an equivocal exam or any other kind of confounding factor, doing an ultrasound, non-invasive, no radiation, no reason not to do it in my mind. So in the private practice, it was a little bit different because there I would see children with a slightly different background, and they were able to get the ultrasound early. And so that was for the first 8 years of my career that I was in Mexico. And then, as you mentioned, I picked up and went to New York, and I was practicing at NYU for 7 years, where it was a completely different environment. And again, you had children from completely different backgrounds, whether it was children who were recent immigrants and didn't really have established health care, or children who were on Medicaid, or whether it was commercial insurance, actually made a difference in the age at which these children were being referred, which is a theme we see with access to care. So in the US, the standard is screening by physical exam and selective ultrasound for high risk. And that was what was being done at the time in New York. And I will say that there were still children who slipped through the cracks, and they didn't all have to come from neglected backgrounds. They sometimes came from pediatricians who simply didn't have the expertise to diagnose this. Which is one of the criticisms I have of the way the screening is established. It says screening by physical exam performed by an expert, but no one states what an expert actually constitutes. And pediatricians are expected to be the expert after their pediatric training, with no one even really knowing if they have trained or have ever felt an unstable hip. So I think it's a little bit unfair on pediatricians. But to this day, that is still the standard in the US, where we have screening by physical exam and selective screening with ultrasound for high risk, which is breech babies, firstborn, mostly breech and firstborn females with a family history. Breech is definitively screened for, but most hip dysplasia occurs in girls. It is more frequent in the firstborns, but a lot of those don't get the screening by the guidelines that are currently in place. So The reality is that I still see a lot of late detected hip dysplasia. I did in New York, I did in Mexico, and I currently do here in Texas.
You brought up an interesting point about your experience in Mexico, where they have the screening protocol and they can identify that perhaps the child has hip dysplasia, but then what happens after that? And it's difficult to really capture what that pathway looks like for them afterwards.
Mhm.
So I'd like to hear, once a patient is diagnosed with hip dysplasia, what would a typical care pathway look like in Mexico, in the United States, where you've practiced, whether it's early
That's
detected or late?
Yeah, that's a great question. And again, it's a highly variable question because there's so many factors that get involved in this. And it's one of the struggles that actually comes up in explaining not only to parents, but even to physicians, and especially when you're talking to, say, health ministries or politicians, that hip dysplasia is this huge variable diagnosis. And hip dysplasia is this umbrella term which encompasses everything, which can go from a developmental dislocation of the hip, a teratologic or very early on dislocation, or a hip which is located at birth but unstable and goes on to develop a dislocation, which each of those has a slightly different management and pathway. If we break it down, ideally, in all of these places, of course, early detection and early management by dynamic bracing has been proven to be the most effective. So in Mexico, if patients were able to come to the Shrine, which again is the only tertiary pediatric orthopedic hospital in the country, then they would come to us. And for most children under 8 months, we would begin non-operative treatment with the dynamic brace, specifically the Pavlik method. And I did say 8 months because, again, they didn't come to us that early, so we extended our upper age limit. It's slightly artificial, 6 months, 8 months. We had 8 months as the marker, and that was the typical pathway. They would come in up to 8 months and they would be treated with the Pavlik method with generally successful results, even in the older children, knowing that the two factors that are related to success with brace treatment are the age at initiation and the amount of time spent in the brace, with earlier age being associated with better results and the time in the brace being associated with better results. So we would try with a Pavlik harness up to 8 months. The younger, the better. And the longer they were in the harness, the better it was as well. That is if you were lucky enough to get into the Shrine, or if you had private health insurance and were able to go and see a pediatric orthopedic surgeon, because that's pretty much the standard of care. The vast majority of children who don't have access to either of these places would then go to one of the, typically one of the government subsidized hospital systems, which provide good care, but they're slightly overwhelmed. And one of the problems here is receiving this tertiary or quaternary care is difficult in a country where this is very spread out. So that still is the ideal. And in fact, we worked on writing some guidelines for brace treatment, which follow international guidelines, early treatment with brace up to 6 months, and then consider closed reduction. But again, it comes down to sometimes the ease of access of getting in to see a specialist, which isn't always available. So they might come in at a later age. I tell people one of my first papers which I wrote up when I was in practice was my experience with open reduction and pelvic osteotomy, which we can get to. But I'm not proud of the fact that I was doing that many open reductions and pelvic osteotomies. The problem was we were getting all these kids who were coming in well beyond the age when non-operative means could be done. So if you're in a place where the mean age is 2 years, then bracing is really not going to be very effective. And I was forced to be doing a lot more surgery, which as a surgeon was good. But again, that may not be the best way to do this. So if they get in early, then typically it is still brace treatment. If they come at a slightly later date, then it begins to break down. And that's one of, again, the I won't say criticisms, but one of the caveats of this screening program is it's all good and fine to identify hip dysplasia, but if you identify it at 6 months, you should have a pathway for this patient to be evaluated and treated. And that doesn't exist in a standardized way across the country because of the fragmented nature of the healthcare system. Similar to the US, it's not exactly the same everywhere you go. So in general, I would say that the guidelines were followed, 0 to 6 months brace treatment, 6 months to 12 months, closed reduction for dislocations of the hip, above a year, open reduction, and above 18 months, begin to consider some bony surgery is the sort of cookbook, algorithm for this. And again, it kind of depends on which system the patients are in. And again, to reflect on how that translates into the US, it's actually remarkably similar. And one of the things I have found is, despite differences in the way healthcare is provided in different countries, the objective is the same, and the families want the same. They all love their babies, and they want the best for them. So in the US, fortunately, once a baby is diagnosed, they tend to get sent to the right place quicker than they would in a developing country like Mexico. But in general, it's still kind of the same approach. If you're in a system which has the specialist who is needed to see you at an early age, then brace treatment up to 6 months. And after that, it begins to get a little bit more complicated.
Thank you for sharing that. I think it's clear that there are certainly still more opportunities, for growth and innovation related to hip dysplasia care, research, and education. So can you share also what the priorities are for hip dysplasia care research and innovation in Mexico versus the United States, and how you're involved in those activities to address some of those priorities?
Sure, absolutely. And that's, again, I love that you've set up these questions because there are almost two different answers when you talk about Mexico or the US. Because the reality of the economy and the state of healthcare delivery is different in both of these. Research is crucial to advancing what we do and to improving the outcomes for our patients. But in a system which is overburdened with providing healthcare and which doesn't incentivize research in any meaningful way, it's very difficult to do any kind of research. I don't feel that I am a particularly research-minded person. I'm not a basic scientist. I am a surgeon. And what I am is I'm pretty obsessive about my results and my outcomes. So I began to track all my patients. And because I was able to do that, I was able to produce some research, which is retrospective reviews of my own cases, which is valuable, but not what we consider, the highest level of research with a prospective randomized trial, which could be done. It still made me a bit of an outlier in Mexico, where really not much research was going into this, again, from the standpoint of the providers who are already overburdened. Having said that, there is research ongoing around the world, and I have been able to be involved in a number of different ways. And I'll go back to the International Hip Dysplasia Institute, which was founded almost 2 decades ago, by Dr. Chad Price in Orlando. And this was a global initiative to address these sort of gaps in the knowledge that we have, and the fact that screening is not done in a worldwide standardized fashion. The treatment is not done in a standardized fashion. Even the outcomes that we're measuring are not the same in different places in the world. So I was very fortunate after my 8 years in Mexico to be recruited to New York. And I was thrilled to be in an institution, NYU, where research was highly valued. And I was able to progress a little bit more and take this to the next level with looking at these kinds of things, of standardizing outcomes, of trying to find ways to standardize pathways. And I think that is one of the key areas of research. What we need to look at is how do we improve the early diagnosis? And one of the things that we discussed at length was the reality of healthcare provision and who is seeing these patients. Most patients in the world don't see an orthopedic surgeon, but most of them do get to see a pediatrician. So from a early diagnosis standpoint, our efforts should probably be directed more at pediatricians, general practitioners, and family medicine physicians as the gatekeepers, the ones who have more contact with these patients. Once they get to orthopedic surgeons, they're probably slipping through the cracks if they haven't been identified before then. So research worldwide should clearly be directed at improving the ease of diagnosing hip dysplasia at an early age. We know that that's related to the best outcomes, and we know that we can do that. We know that with modern techniques like ultrasound, we can improve the early diagnosis. There are obviously other things that are moving forward. The surgical treatment, which is, as surgeons, what we're interested in. We, as much as I advocate for early diagnosis and early intervention with non-operative means, and we know that's by far the best. In full disclosure, I'm still a surgeon, and I like treating things with surgery because that's what I trained to do. So I think there should be a push to improve diagnosis and early treatment, which can be standardized. And that should be relatively easy to do because it does remove some of the inherent variability and individuality which is required from surgical treatment. And then as we move on to surgical treatment and surgical outcomes, I think we're moving towards less invasive treatments, towards more personalized treatments for the variants of hip dysplasia that we identify, and better techniques to preserve and stabilize the hip joint.
Certainly. I think those are all such important priorities and something that has been really illuminating with this series where we're talking with surgeons from around the world is seeing that it really isn't that standardized. There are so many variabilities from screening all the way through treatment and even the post-operative pathway after that. So it's really interesting to hear these perspectives. And I agree with what you said about bringing more awareness to kind of standardizing those protocols and how that can optimize patient outcomes. One thing that I would like to end on is what your vision is for the future of hip dysplasia.
Well, that's again another question which I could ramble on for hours, and I know that you don't want this to last too long. So ideally, we can't really talk about preventing or eliminating hip dysplasia because it's such a ubiquitous finding, and there's no real way of preventing it. We know there's things that can improve the likelihood of presenting it, like avoiding swaddling, sort of identifying this in an early way. But I don't foresee a future where there is absolutely no hip dysplasia, at least not in the near future, because even if this was diagnosed in utero for a true congenital hip dislocation, there's no treatment that could be given at that time. And with this being a developmental condition, it's likely happening around the time of birth and in the subsequent months. So I don't think we're going to see a world without hip dysplasia, but my vision would be a world where hip dysplasia is detected in an early way and treated non-operatively to avoid the long-term consequences that we know then lead to pain and adverse outcomes in the long term.
I think that's the perfect vision and perfect way to end this conversation that has been so insightful and wonderful. So thank you, Dr. Castaneda, for sharing your global perspective on hip dysplasia care.
Absolutely. It was my pleasure, Lauren.